Hello, everyone. I'm Dr. Mark Rosenberg, Vice Dean for Education and Academic Affairs at the University of Minnesota Medical School. Welcome to the first session of Mini Medical School Evolving with the Pandemic. We are excited to have you here today, and we look forward to guiding you through our first topic in the series, the latest on COVID. The way this will work is we'll begin with a moderated discussion followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. Please note that this session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email. Today, we have the pleasure of speaking with a panel of experts on new COVID variants, the impact of the pandemic on rural communities, and the spread between people and animals. I will first bring in Ryan Langlois. Dr. Langlois is an associate professor and McKnight Presidential Fellow in the Department of Microbiology and Immunology in the medical school. His research focuses on immunity to influenza virus infections. Dr. Langlois, can you talk about COVID variants and subvariants? What are they, and could they be resistant to treatment?
Yeah, thank you so much, Dr. Rosenberg, for the intro and for the question. So, like all viruses, SARS-CoV-2 will continue to mutate, right? And so every time this virus replicates, it will make mutations. And viruses will actually mutate substantially faster than the genes in people or other animals. And this gives them sort of an evolutionary advantage when they're in a population. So as these viruses continue to mutate, they evolve. And what we think about with viral evolution is called virus fitness. And really what that means is as that virus mutates, is it going to be better at transmitting and replicating from one person to the next person? That's really the only factor that matters. And so that's how these new variants have arose. So the original variant in Wuhan was unfortunately good enough at replicating in people. It was able to spread. The next variant had a slight advantage over that original strain. And so they slowly replaced the original strain. And so unfortunately, as we've now had many millions of people infected, we've given this virus a lot of opportunities to mutate, change, and create new variants. And so now we're dealing with the newest variant, Omicron, which is clearly better at replicating and spreading between people. And so now what we're looking for are subvariants, right? Are there little changes that are happening to Omicron that might make that variant better at replicating than the original Omicron? And the second part of your question is really important. Is this going to make this virus resistant to therapies? And the answer is we don't know. So all of these changes could allow the virus, for example, to escape antibodies, the component of your immune system that's really important for fighting these infections, and it's the target for vaccines. It's clear, fortunately, that these vaccines can still provide some protection against Omicron, but it's not as good as the original strain. And then we now are really fortunate to have a number of antiviral drugs coming on the market. And so it is possible that a future variant might be resistant to those, although fortunately right now, it appears that most of these other drugs are still able to function against the current dominant variant on the planet.
Thank you. So let's get into more about the protection and treatment of COVID. Let me ask you two questions. There's been a lot in the news in the last day or two about boosters and having a fourth booster if you're over age 50. Will boosters be needed every year like a flu shot? And then can you tell us more about these antiviral medications? Where do people get them and when should they take them?
Yeah, great question. So I think I don't unfortunately have a crystal ball, but I think it's almost certain that we will need to continue to get booster shots for the foreseeable future. Very, very likely we will have variant-specific boosters in the future, but I think even the original boosters from the original strain are still going to provide a significant increase in protection. So I think it's not unlikely that we will have to have annual boosters for SARS-CoV-2 for the next several years. There are sort of several new drugs that are coming on the market and becoming available, which is really fantastic. And so I'll just take a really brief moment to just mention how viruses work and how scientists have found ways to stop it. So viruses can't replicate on their own. They actually need to use our own host cells to undergo their replication cycle. So the very first step of a virus infection is getting inside of your cell. That actually creates a significant barrier. And so antibodies are one key place that can block and prevent the virus from even being able to enter and replicate in the first place. And so the antibodies are the components of your immune response that are elicited by vaccination. And so scientists have taken advantage of this. And what we can do is we can make antibodies in the lab. We call them monoclonal antibodies because they just target, they're just an antibody against a single target. And so those can be used and delivered to patients to be able to prevent infection or to stop an infection that already exists. A major downside of monoclonal antibodies is that they're very, very expensive to generate. And they also have to be given intravenously. So a patient would have to go into an inpatient setting where they would get an infusion. So let's say, unfortunately, the virus is able to get through that first barrier and it can enter. Now the virus has to replicate. And so these viruses replicate using something called a polymerase. And so there are now several drugs that can target the viral polymerase. The first one that many people probably are aware of is remdesivir. And remdesivir actually works quite well. The biggest issue is it's difficult to give remdesivir early. Because remdesivir requires intravenous administration, it needs to be given within a hospital setting. And so like all antiviral drugs, earlier is better. And these drugs are going to be much more efficacious if given earlier than later. The next drug that fortunately is oral, which can also block the viral polymerase, is molnupiravir. And so this drug basically allows the virus to actually mutate way faster than it normally would. And all those new mutations accumulate, result in this, what we call an error cascade. And so the virus essentially kills itself by mutating too quickly. And so that drug also seems to be highly efficacious, but again, its efficacy is completely tied to the timing of delivery. And so the earlier that drug can be given, the better. So after the virus replicates, it will produce all kinds of proteins, these little pieces of the virus that it uses to do things, right? And so one of the keys that SARS-CoV-2 needs to do is it needs to make a protein called a protease. And that protease will actually go into the virus and it will chop up a whole bunch of the proteins into smaller proteins, which can then go on and do their job. And so by stopping this protease activity, you can actually stop the virus in its tracks. And so one of probably the best drugs for SARS-CoV-2 now is called Paxlovid, and that blocks the viral protease. And by blocking the viral protease, you can effectively stop the virus from being able to use its protein weapons against the cell. So that drug, Paxlovid, is given orally. So fortunately, it can be given in an outpatient setting. And again, its efficacy is completely tied to timing. So the sooner you can get Paxlovid after a diagnosis, the better. Unfortunately, right, these drugs are just coming out and coming online, and so they're not available in incredibly high numbers yet, but that is rapidly changing, and hopefully we will see these becoming even more broadly available in the near future.
Thank you. Fascinating. Now let me introduce Carrie Henning-Smith. Dr. Henning-Smith is an associate professor in the Division of Health Policy and Management in the School of Public Health at the University of Minnesota. Her research works towards moving health equity for all, with a particular focus on historically marginalized populations in order to illuminate structural barriers to health and well-being and practical policy solutions. Dr. Henning-Smith, can you tell us how COVID-19 has impacted rural communities?
Yes, thank you so much for that kind introduction. I'm really glad to be here. So, just as by way of introduction, why would we talk about COVID in rural communities, and why would we talk about it as though it's different than COVID in urban communities? COVID-19 began in 2020 as a distinctly urban phenomenon in the United States, but it quickly became a very large issue in rural places across the country. And in rural places, both risk and resilience factors are different. Next slide, please. Even before COVID-19 emerged in the world, rural areas in the United States face significant health disparities relative to urban areas. Rural residents were also different than urban residents in ways that have serious implications for the way that COVID-19 rolled out. First, demographically speaking, rural areas are older on average and have lower median incomes, lower educational attainment, higher poverty rates, higher rates of uninsurance, and higher rates of unemployment compared with urban areas. So that was the demographic situation before COVID-19 hit the scene. Rural residents also have lower life expectancies, higher rates of disability, and higher rates of underlying health conditions than urban residents even before COVID-19. This slide here shows one example of that. This shows rural-urban differences in death rates from the 5 leading causes of death: heart disease, cancer, unintentional injury, respiratory disease, and stroke from 1999 to 2014. For all 5 conditions, the death rate is consistently higher in rural areas, and in some cases, that gap has widened over time. That was the landscape that COVID came into, and those are some of the risk factors that were already present. Next slide, please. But particularly relevant for thinking about the COVID-19 pandemic, rural areas also have and had more limited access to healthcare. One example of that, and potentially the most prominent example of that, is rural hospital closures. This map on the slide shows where a rural hospital has closed anywhere in the country since 2005. You can see that here in Minnesota, we have not been immune from rural hospital closures. Since 2010, 138 rural hospitals have closed across the country. 19 rural hospitals closed in 2020 alone, the year that COVID-19 was first rolling across the country and devastating places. And in some cases, COVID-19 was the proximate cause for the hospital closure. Approximately half of all rural hospitals today that are still open operate in the red on an annual basis, and not being able to do routine and elective visits and procedures during COVID-19 really further strained the finances of many rural hospitals. It's not just hospitals, though. In addition to that, rural areas face persistent healthcare workforce shortages at all levels, all of which have been made worse by COVID-19. Nearly 80% of rural areas are designated as medically underserved areas. Rural residents live further on average from emergency rooms. Rural counties are less likely to have ICU beds or ventilators available. And structurally speaking, rural areas have different infrastructure. They are less likely to have reliable broadband internet and cellular connectivity. That has made it difficult to be able to access healthcare virtually, but also to access education and employment opportunities and social opportunities and all of the other ways that we have moved online during the pandemic. It's not lost on me that we're talking about broadband and we are meeting with one another virtually. That is harder to do in some rural places. Next slide, please. So as I said, COVID-19 began in the US as a very urban phenomenon. In those very early weeks, you might remember back to stories about Seattle and New York, New Orleans, New Jersey. It did not take long for it to become a rural phenomenon, however. By April 30th of 2020, 85% of rural counties had at least one case, and more than 30% of rural counties had at least one COVID death. Today, it's virtually every rural county. This chart here shows that once COVID got into rural areas, it took off, and it took off faster than it did in urban areas. This is from the very early months of the COVID-19 pandemic, but you can see the rate of increase of COVID was much higher in non-metro or rural counties than it was in metro or urban counties. Next slide, please. So let's bring this up to the present day and see what's happening now. As of last week, rural infection rates are higher than urban, and they have been higher for many points throughout the pandemic. Rural areas have sometimes lagged behind urban areas in surges, but have almost always caught up and even surpassed urban case rates. Next slide, please. Perhaps more telling and much more concerning, though, is the rural-urban difference in COVID-19 death rates. Rural residents have had higher death rates from COVID for the majority of the pandemic. As of March 19th of this month, the COVID-19 death rate in rural areas was twice that of urban areas. Next slide, please. So there are many, many reasons for the rural-urban differences in infection and death rates, and we could talk about them for hours, but we don't have the time for that today. But one large contributor is the difference in vaccination rates. As of mid-February of 2022, less than half of all rural residents have been vaccinated against COVID-19. That's compared with almost 2/3 of urban residents. Other contributors include higher rates of underlying health conditions, older age, lower health insurance rates, reduced access to healthcare. Rural residents also have less access to paid sick leave and other structural barriers that might make preventive behaviors and social distancing more challenging. Next slide, please. And in this last slide, I find it really important to mention and articulate that rural areas are not monolithic. So I've been talking about them as one big thing, but there's incredible diversity across rural areas. This map here shows different majority racial and ethnic groups in the rural counties in the country. It's worth noting that rural counties, those in color here, not those in gray, are the majority of the country. And we have considerable racial and ethnic diversity. Approximately 1 in 5 rural residents today is a person of color or indigenous. Those individuals face higher risks from COVID-19 for all of the reasons we already discussed. They're more likely to work in low-wage jobs, including many essential services, less likely to have access to healthcare, and more likely to have underlying health conditions. However, there are some very bright spots within rural areas and an incredible amount of resourcefulness. Rural areas are smaller, and sometimes that's an advantage, allowing them to be more nimble and innovative, but only if they have sufficient resources to do so. I'll end there, and I look forward to our discussion.
Thank you, Dr. Henning-Smith. And now let me introduce Jeff Bender. Dr. Bender is a professor in the Division of Environmental Health Sciences in the School of Public Health at the University of Minnesota. He's a veterinarian and public health practitioner, as well as an internationally recognized expert on diseases at the human-animal interface. He has directed and collaborated on a broad range of research and surveillance projects pertaining to infectious and zoonotic diseases. Dr. Bender, can you talk about the spread of COVID-19 between people and animals? What do we know, and what does this mean as the pandemic evolves?
Great, thank you for the introduction. And let me show just a few slides just regarding to try to answer some of these questions that you brought out here. So maybe next slide. This first one is busy, and I apologize right up front, but it does talk about virus origins. And so it kind of brings full circle our initial speaker and what he was bringing together. But one of the things to take away from this is that, you know, there are a fair amount of things that we share between humans and animals, and one of those is viruses. And particularly when we look at coronaviruses and we look historically at coronaviruses, we generally have a number of animals that serve as the source as well as kind of intermediate sources. And so bats have always has been really one of the main sources for especially our emerging coronaviruses, such as the one we currently have. Next slide. And many of these have actually been quite newsworthy events that we have seen. So we've actually, you know, in the last month, you know, there was a big concern and scare about hamsters in Hong Kong. And actually, you can see there's a lot of white suits out there. They're actually closing this particular pet store down. They're destroying all the hamsters just because of the concern and detection of SARS coronavirus in hamsters and the concern that it might have spread to some of the workers there. At the same time, too, we've had, you know, significant outbreaks, especially in Europe initially with mink, and actually not only there in Europe, but also in the United States. And the concern again that that transmission was ongoing not only among the mink and spread rapidly among the mink and caused significant disease, but also that there was concern about transmission to humans. Next slide. So in the United States, the US Department of Agriculture has really been tracking and confirming cases in animals. And so this chart highlights, you know, where we've seen it. So you can see that dogs and cats are there, and most of those are because of the human-animal interaction. You know, sick humans actually, you know, love to have a therapy animal to help them through during the time that they're sick. And so subsequently that does spill over occasionally to dogs and cats. And so there have been a number of dogs and cats in households of ill humans who have subsequently been positive. At the same time, you also notice that there are tigers and lions and gorillas and snow leopards. And so this actually created a different challenge as to, you know, what are the concerns in zoologic parks and why is this occurring and why are these animals getting sick? So that is actually another concern that has been raised. And most again are due to ill caretakers who are working in the zoo that transmitted it to these animals. Next slide. And this brings me to one of the concerns that we've seen recently, and kind of a disturbing concern. And this has been the detection of SARS coronavirus in deer. And maybe next slide. A couple things that really stand out when you look at kind of the barrage of information that we've received through a number of studies across the country is that deer seem to be easily infected, and actually they seem to be getting it from a number of human sources. So through whole genome sequencing, we can link that, hey, this strain was emerging in the community and among the humans, and then subsequently we are seeing this in the animal populations, in particular deer. The other thing that's been a little bit disturbing with deer is that it seems to be efficiently transmitted between deer. You know, they sometimes are communal animals, they sometimes share common environments, or they do. And so that efficiency of transmission, in other words, they're probably not only are they getting infected from the humans, but then they're making enough virus to then subsequently infect their herd mates, if you will. And with that, there's also been some evidence, though limited, of what we call spillback. In other words, human, you know, or animal to human, so human to animal transmission, but then also then back to humans as a result of that. And that's actually one of the main concerns or questions is, could the white-tailed deer serve as a reservoir for new viruses, new virus variants that actually could spill back into the human population? Next question, or next slide. Yeah, and that brings me to maybe just to summarize this, some of the work that we've been doing here in Minnesota. just to highlight some of the work that we've been looking at in animals. And so next slide. So with funding from the Centers for Disease Control and the Council for State and Territorial Epidemiologists, we have a project that's been looking at these spillover events. What happens, or which animals are actually getting the virus, and then also what precautions should we be taking, especially in those facilities where we have human-animal interaction. Next slide. And so I apologize, this is a really small slide. So for those of you like mine who have aging eyes, it's a little bit tough to see, but this highlights really a summary of the animals that we've sampled since June and our partners. And so, we've sampled well over 500 animals. The majority of these were actually sampled at the Wildlife Rehabilitation Center here in the Twin Cities, one of the busiest rehabilitation centers in the US. With nearly 400 animals. The good news is that we've sampled a whole bunch of animals, including bats and squirrels and possums and cottontail rabbits and raccoons, and they've all been negative. So basically, of 400 animals we've sampled, they've all been negative. We also work with the Department of Natural Resources and with deer, and 9 of the 142 deer that we sampled were actually positive. We've been working with the Metropolitan Mosquito Control District, who's worried about tick and mosquito issues, but also they sample rodents to actually look for ticks. And so as a partner, we've sampled white-footed mice, and those have all been negative. And then we've also worked with the Twin Cities Coyote and Fox Project, so understanding the urban wildlife issues, and we've sampled a number of coyotes and foxes, and those have all been negative as well. Next slide. As part of the project, we've also been sampling humans. And so at the Wildlife Rehabilitation Center, there have been 50 willing folks, volunteers, who have submitted a nasal swab when they were working, and we've been testing them. And of those 50, one individual actually tested positive. That actually was an individual during the Omicron surge in December that we saw there. And then these are, these individuals, some are vaccinated, actually the majority of them were vaccinated, and a small percentage actually had a history of previous infection as well. Next slide. And that just brings me to a little bit of a reminder of basically our sampling that we did here. So this was an opportunistic sampling of deer during the hunting season, working with the Department of Natural Resources. And this is part of their project. They're looking at a particular disease called chronic wasting disease. And so we were opportunistically sampling lymph nodes at that time. And this is where we saw that 6% of the samples were positive for white-tailed deer. The reason I reemphasize this is that if you've looked at the news headlines, in some areas of the country, the rates are actually higher, much higher. For example, some studies that have been done in Iowa have shown that up to 40% of the deer that they sampled were actually quite high. Now, as to why there's a difference between Minnesota and Iowa, I don't know at this point, but I just wanted to raise this point. Next question, or next slide. And so the last thing I wanted to say is that we have a project, an ongoing project, really targeting and supporting animal exhibition areas, or basically areas where human animals can interact. And that would include our regional zoos, the wildlife sanctuaries, rehabilitation centers, again, areas where human and animals interact. And we're trying to collect information about their infection prevention and control measures, interviewing basically zoo directors and animal care staff, really to understand how to best protect both the animal and the human populations there. And so that's just a brief overview, a little bit of some of the animal related issues and things that have been happening. So I'll turn it back over to you, Mark.
Thank you, because I'm going to ask a follow-up question, but in my mind, I was just imagining how you do a nasal swab on a lion. But Dr. Bender, before the pandemic, farmers, farm workers, and their families were experiencing lots of stress, uncertain weather, animal illnesses, fluctuating markets, unforeseen disasters. And it seems like COVID has now added another layer of stress. Can you talk a little bit about how COVID has impacted our farm country and what resources may be helpful for our agricultural communities?
Absolutely. And actually, Dr. Henning-Smith just did a wonderful job really pointing out the challenges, especially in our rural communities. And this is very, very true, especially for our farm workers, our producers, and our farm families. So yeah, I can't emphasize that. I have a couple, just a quick slides, if I could go to the next slide set on those. But one of the things just to remind folks is that when we look at, next slide, if we look at Minnesota in particular, we have a strong immigrant labor force that actually supports. And I specifically point out the dairy industry. Really, if you look at Minnesota and Wisconsin, 51% of the workers on dairies are immigrant workers. And if you look at overall milk supply in this country, virtually 80% of our US milk supply, needs immigrant dairy workers for that. And so it's really important for us just to kind of remember that and remember that heterogeneous nature of our rural communities. Next slide. And this gets to the issue of what do these communities need and some of the requests that they have. Really, one of the things that we found in really working with our agricultural community is that they just needed information as to what do we do with the pandemic and preparedness. How do we prevent infections? A lot of there's congregate housing situations. How do we actually try to minimize spread in that type of setting? We share a van as we move to the fields or different areas. How do we actually deal with that? So that's an example. The other is diagnostic challenges, especially in rural communities. Also vaccine access or availability, communicating with local public health. And then lastly, one of the big things that we really still see is the issue of mental health support for our agricultural community. Suicide rates are much higher. Basically, depression scores and anxiety scores are much higher in our rural communities. And this is not exempt in our immigrant communities as well, but this broadly across our rural communities. So I just want to reemphasize that key point. So I'll turn it back to you after those comments.
Great, thank you. And we're going to move on to the questions submitted by our attendees, and I'll address them to specific people. And thank you, attendees, for the amazing questions you've already submitted. But as a reminder, just click the Q&A button at the bottom of your your Zoom screen. So I'm going to start off with Dr. Langlois. For individuals eligible for a second booster dose, do you recommend mixing and matching? So Pfizer, Moderna, back and forth. So homozygous or heterozygous boosters?
Yeah, it's a great question. And I think the data now is clear. I would recommend it. So I'm a Pfizer person, I guess. All three of mine have been Pfizer. And so when the next boost is available for me, I will certainly get Moderna to mix it up. So I think it's a good idea, and the data is clear. The antibody responses are stronger and more durable.
Yeah, why is that?
Well, so the short answer is we don't know, but I think the easy hypothesis, right, is that there are slight and subtle changes between those two, and the immune system is good at seeing and responding strongly to slight and subtle changes. So I think that's the best idea we have right now, but we still don't know, and people are looking into it.
Great, thank you. Dr. Henning-Smith, the hospital closures in rural areas was really scary. There was some questions about what were the blue and the yellow dots, but can you talk a little bit more about why these rural hospitals are closing?
Yes, first I can address the blue and yellow dots, and I apologize for not explaining those when I had it up on the slide. The yellow dots were hospitals that had closed between 2005 and 2009, and the blue dots were hospitals that had closed since 2010. Those images all come from the University of North Carolina and their Rural Health Research Center. And for anyone who really wants to look at this sortable list of hospitals, I recommend looking there. In terms of why rural hospitals close, there isn't one villain here. There are several issues at play. The big one is hospital finances. You have more people without access to insurance. and you have a lower income population and people with greater need, and all of that results in uncompensated care for hospitals. We've seen more hospital closures in states that have not expanded Medicaid and that don't have that strong safety net in place for the population. So finances are a big one. It's also very expensive to keep a low volume hospital open and operational when you don't have that many patients coming through the door, but you need to keep it staffed, you need to keep the lights on, you need to keep the heat running. And then another big factor is just availability of workforce. There simply are not enough people at all levels of the healthcare workforce in rural areas to keep hospitals staffed.
Thank you. Dr. Bender, is there a vaccine for our pets, for our dogs and cats, and should we be vaccinating them as well?
There isn't a licensed vaccine for animals. However, many zoos, especially with the value of the stock that are there, are vaccinating their animals I'd say that there is a vaccine from a company called Zoetis that actually is available for the animals, but basically it's under kind of restricted use as well, and it really is targeted in that regard. So I correct myself in saying, no, we don't have a vaccine for dogs or cats, and it's really limited actually for this particular vaccine for zoo settings.
And then since you mentioned deer, there was a question about whether we're seeing it in wild deer as well as in deer farms.
Yeah, actually, the work that's been done and the published studies have been done have all necessarily been either experimental situations for deer or have been in wild deer populations. As you can imagine, farm deer situations where there's much more human interaction, they probably are picking it up as well. And so there is a potential risk there.
Thank you. Let's go back to Dr. Langlois. You mentioned that early administration of this antiviral treatment is crucial. What would you consider to be the effective time frame after someone has a positive COVID test for administering any of these antivirals to get maximal treatment success?
Yeah, I think it's a great question. For maximal success, it seems like within the first sort of either 3 days of symptom onset or the first 3 days of a positive test. Now, that being said, that's when it's going to work the best. These drugs still do work very well for patients who are in a later stage of their disease. It just won't work as well if you catch it within that sort of first 3-day window.
Thanks. Dr. Henning-Smith, the COVID pandemic has taught us so much about delivery of healthcare, the use of telemedicine, the way we even educate our students. What have we learned from the pandemic that we can use to improve rural care?
Oh my goodness, that would be a long list. I mean, I think first of all, we've learned, and we knew this already, but COVID really emphasized the fact that we need to address underlying inequities, both in things like access to income and employment and health insurance, but also in infrastructure, access to broadband internet, affordable housing, a living wage, all of those structural issues that impacted people's risk throughout the COVID-19 pandemic. And I think there are a lot of valuable lessons from the increase in telemedicine, but we can't really capitalize on those until we address some of those bigger structural inequities to make sure that everyone has access.
Thanks. Dr. Bender, what precautions should hunters take to avoid possible infections from deer? And is deer meat okay to eat if a deer has a positive COVID test?
Yeah, good question. Actually, something that we wrestled with, especially as we were working with the DNR during the hunting season. And this is something that we had addressed right up front because we were anticipating that many hunters would have that question. And so, yeah, the risk to hunters would be very minimal. They're not letting the animal sneeze on them or breathe on them. And so the transmission or likelihood of transmission of basically the virus, it's going to be in the upper airways. Now, in processing that animal, there's going to be some recommendations of, wearing gloves, washing your equipment, washing your hands. And even the CDC has suggested that during processing, it might be beneficial to wear a mask as a way just to keep things away from your nose and mouth. So those are some of the key things. And that's in a sense, that's some of the general recommendations anyways, to prevent a number of potential bacteria that can be, or viruses that could be in meat products, like things like Salmonella and Campylobacter and E. coli, that we can sometimes associate with basically undercooked meat in that regard. So the question specifically, could meat itself be a source? No. Basically, where they're seeing replication of the virus is usually in the lymph nodes and in the upper respiratory tract in that regard.
Thank you. Dr. Langlois, you mentioned, this is one of the questions that came in, that there are stories, incredible stories of people developing autoimmune diseases after receiving the vaccine. Can you discuss this, a little bit about the risk of vaccine?
Yeah, I can just briefly mention this. So I actually am not aware of credible stories of autoimmune diseases arriving from the vaccine. So, this has been something that vaccinologists, immunologists have looked at incredibly carefully because of a history of Guillain-Barré with a previous influenza vaccine. And so the vaccine reporting system through the CDC is very, very, very good at catching things. And one major issue that we've seen with SARS-CoV-2 vaccines is that so many people on planet Earth have gotten them, which is wonderful. But that also increases our visibility into incredibly rare events. And so I think, given all of the data we have seen so far, these vaccines are incredibly safe. And I don't think that there is any strong risk or association with SARS-CoV-2 vaccines and autoimmune disease.
Thanks. Dr. Henning-Smith, will COVID be slower to end in rural areas once we reach an endemic phase?
Well, like my co-panelists, I wish I had a crystal ball, and I don't. But I suspect that it will, especially in those communities with particularly low vaccination rates. We have some rural communities where vaccination rates still hover in the 20 or 30th percentile. And in those places, it's going to be able to spread and have a more severe effect while it does spread.
And that was the question I was going to ask everybody, was when is COVID going to be done? But maybe we'll leave that. So Dr. Bender, have there been any instances of transmission of COVID from dogs to humans? And what would the symptoms be like if a dog did become infected?
Yeah, one of the interesting things that has been done is actually characterizing why certain animals seem to be more susceptible than others. So, for example, cats seem to have a higher degree of susceptibility to the virus than dogs do. And there have been no instances of dog to human transmission. And it's probably based on basically their host's susceptibility and their ability to replicate the virus. So that's the good news. So please don't get rid of your dog, nor your cat in this regard. So no, at this point, we've not seen any evidence of dog to human transmission.
Thank you. Dr. Langlois, question about the Moderna vaccine. Is the fourth booster going to be half dose again?
Oh, that is a great question. I have not looked up the answer to that, so I do not know. I would suspect the answer is yes, but that's just a guess. I haven't looked specifically.
Great, and let me give you one other one. I mean, how do these viruses know to evolve? And is there is evolution of the virus, possible even in a fully vaccinated, boosted person?
Yeah, great question. It's easy to want to personify viruses into this, right? And they don't want to evolve. They're just dumb machines that are making mistakes and replicating. And unfortunately, sometimes those errors that they make are advantageous to the virus. And then those viruses that have the advantageous mutation win in the global competition against all of their brothers and sisters. And so unfortunately, it does seem clear now that these viruses can evolve in vaccinated people, and that unfortunately the protein in SARS-CoV-2 that's evolving the most rapidly is the spike protein. That's the protein that the vaccine targets, and that's also the protein that allows the virus to enter cells. And so just as a quick example, when we've sort of moved from Delta into Omicron, there were 30 mutations in the spike protein, and that's a lot. In the proteins that are targets of some of these antiviral drugs, like the polymerase or the protease, there were only one or fewer mutations in those genes. So it is clear that our immune systems are putting a heavy amount of pressure on the virus to evolve.
Can you talk a little bit about the BA2 variant, which my understanding is now the most common variant in Minnesota? Where are its mutations?
Yeah, unfortunately, its mutations are also in the spike protein, which are probably allowing it to do a couple of things. It unfortunately is probably able to better bind and enter cells, and it is almost certainly better at evading antibody responses. Not perfect at evading those responses, just better, and slightly better enough that it seems clear that this BA.2 variant will outcompete the original Omicron, probably over the next month or so.
Thank you. Dr. Henning-Smith, for rural communities, how can providers and those passionate about rural health or those who have hesitant relatives up north emphasize the importance of vaccines to the community?
Yeah, it's a great question. And it's one that, again, I wish I had a really simple and clear answer to. I can't tell you how many meetings I've been in over the course of the pandemic at the local, state, or federal level to try and figure out what is that answer. How do we help people trust the science? How do we help people trust public health? There unfortunately is a lot of mistrust out there, and some of that mistrust is higher in rural communities. And very, very unfortunately, and really tragically, COVID-19 became politicized even at the very beginning of the pandemic. And we're seeing the implications of that now in lower vaccination rates among rural communities and higher death rates. And I wish that weren't the case. It's really, really a tragedy. In terms of how to convince people, I don't think there's one right answer. I think it's having conversations, trying to meet people where they're at, trying to share your own understanding of the science, trying to point to where there is good science, and continuing open communication, continuing those relationships. And in rural communities, finding who those trusted messengers are, who are on board with the science and pro-vaccine. How do we get their voices to be amplified within their community?
Thanks. And you mentioned higher death rates. Is that vaccination related? Is it access to rural healthcare related, or lots of factors?
It's lots of factors. We had a population that was at higher risk to begin with. It's an older population. It's a population with more underlying health conditions, more chronic conditions, and reduced access to healthcare. And so once COVID got into rural populations and rural areas, it was more lethal. It is more lethal. And on top of that, we have a population with significantly lower vaccination rates, so less protection against the virus once it's there. So it's all of the above and mixed together. It's a really dangerous combination.
Thank you. Dr. Bender, are non-mammalian animals subject to COVID-19?
No. We haven't seen it.
Great. Thank you. One follow-up question, Dr. Bender, is what's the treatment and death rate of animals with COVID? And does the local vaccination rate in people impact the rate of animal transmission?
Yeah, so again, our animals are not as susceptible as people. And so, the symptoms that they display are actually fairly mild. Generally we don't see deaths. We have seen some problems in some of the zoo settings where some of these big cats have gotten pretty sick. They've got upper respiratory symptoms. They're febrile. And so there has been some significant disease in those. And as you can imagine, the gorillas and other non-human primates have similar symptoms to humans. So it varies a little bit. But for the dog and cat, generally very mild, and they generally recover. And so the deaths are not that significant. And in relationship to vaccination, probably that's some of the key things that we've been trying to emphasize to folks. Try to get vaccinated, try to use preventative measures. If you are sick, then try to limit your contact with your animal, even though it's a little bit of a therapy animal, if you will. And actually, I think I saw a question come up regarding therapy animals. The basic thing with therapy animals is preventing ill humans from actually accessing those pets. So one of the things that we do with our therapy program here at the University of Minnesota is that people have to wash their hands before they touch the pets, and after they touch the pets too. So we don't discourage the therapy program, just recognize that humans are probably the likely source.
Thank you. Dr. Langlois, what do we know about the effectiveness of the COVID vaccine in younger children, let's say between age 5 and 11?
Yeah, I think it's pretty clear that it's still highly efficacious in this population. There's a few things that make it a little bit difficult to fully assess. One, the numbers are significantly lower than the numbers to evaluate are significantly lower than for folks older than 12. The other thing is that they're now confronting the variants, right? So they're vaccinated with the original strain, and they've only been able to be vaccinated and face variants, unlike adults who were able to be vaccinated and face some of the ancestral strains where vaccine efficacy was much higher. So I think it is clear that it's still highly efficacious, although it's not as efficacious as it was against the original strain, unfortunately.
Thanks. And another follow-up, Dr. Langlois, regarding boosters. Are the boosters evolving along with the virus, or is it still the same booster that people got during their 3rd dose or even their first 2 vaccinations?
Unfortunately, it's still the original strain. And I will admit this is a major source of frustration for me personally. One of the major benefits of RNA vaccine technology is that it's highly rapid, adaptable, it can be quick and nimble. And I think that as a country, we are not taking advantage of that critical feature of these vaccines. I will say one concern is that you switch to a variant, right? And then that variant may be rapidly replaced from the population, right? If you vaccinate against Delta and then now all of a sudden Omicron looks totally different than Delta, I get that that's a concern, but we have the technology to move quicker with variant vaccines, and I think we should.
So can you imagine a time when it will be like influenza, that each year a new vaccine is manufactured that people will take as their COVID booster?
I think that that's almost certainly likely. I think one thing that is still happening that is clear is SARS-CoV-2 is still evolving to live with humans, right? It is not fully evolved to its new host. We are still a relatively, evolutionarily speaking, we are still a relatively new host. So once that does happen, and it is sort of better attuned to us, I think you will see fewer variants. I still think that there will likely be annual variants that we'll need to confront, but it won't be sort of the whack-a-mole game that we're playing now. At least that's my hope based on the data I've seen so far.
Great, thank you. Dr. Henning-Smith, going back to rural hospital closings, how can populations be supported with so many disparities present, and how can rural hospital closing be combated with the problems that you mentioned of finances and low workforce?
Yeah, just as there are many causes for rural hospital closures, I think there are many solutions, which makes that sort of exciting. I think first and foremost, expanding Medicaid in states where that hasn't happened yet will go a long way toward making sure there's not quite so much uncompensated care. But we also need to address the workforce issues that can happen through financial incentives, loan forgiveness, bonuses for people who practice in rural areas. But there's also a lot of promising work around pipeline programs, talking with high school and even younger kids about moving into the healthcare workforce that obviously doesn't have immediate effects, but is important for long-term bolstering of the system. And then I think fundamentally it's a question of equity and not equality. Rural hospitals might need a little more support, a little more help to meet the needs of the population, given all the challenges that I outlined. And so that might require a little more support at the state and federal level than some of our larger urban hospitals.
Great. Dr. Langlois, natural infection versus vaccine. If someone has an infection, why are vaccines so much more effective?
Yeah, it's a great question. So, vaccines are designed to drive an incredibly strong immune response without the downside of potentially becoming sick or dying from the infection itself. And so these vaccines, just on a sort of pound for pound basis, will drive more antibodies against the spike protein than if you were to be naturally infected. That being said, there are some benefits to natural infection. I'm obviously not suggesting that that's a strategy on any level, but SARS-CoV-2 has 29 proteins. Your immune system has the capacity to recognize all of these, and so you will get a more breadth of your response, and you'll generate an immune response against some of those other proteins as well. But it comes at the risk of becoming infected, yourself potentially dying, and then also you becoming infected and spreading it to another person.
Great, thanks. Well, we could keep going forever, but we have run out of time. And I just want to take this opportunity to thank Dr. Langlois, Dr. Henning-Smith, and Dr. Bender for the great discussion and the answers to these really complicated questions. And a special thanks to all 500 of you who attended and asked asked such great questions. So thank you. That's our first episode of the mini medical school. But want to remind everybody that next week, same time, same place, next Wednesday from 12 to 1, will be the second pandemic-related mini med school on emotional well-being and resilience in a time of anger and burnout. And we have an amazing group of experts who will lead and answer your questions about that. So with that, thank you to everyone, and we're officially adjourned.